Hello, everybody. My name is John Harrison, and I'm delighted to have this opportunity to share some thoughts on the early identification of patients with Alzheimer's disease. My thanks to the organisers. This is a wonderful opportunity, and I'm delighted to be part of your Congress. So I'll be talking about Alzheimer's screening, primarily cognition. Cognition is my background as a psychologist, but I will allude and discuss lots of other elements of our understanding of the presentation of patients in the very earliest phases of this disorder. So hence the title, Assessing Cognition in Early Alzheimer's Disease. And this is my plan for the presentation. It'll run to approximately 30 minutes. And to begin with, it's a consideration of mild cognitive impairment and the detection of early Alzheimer's disease. I'll say a very little bit about cognition, just to give everybody a flavor of my personal approach to these issues. Talk about some of the challenges that we encounter in both the identification of people that may have cognitive deficits, as well as monitoring the change in cognition that we see over time, and offer some thoughts on how we might contemplate doing things a little better, a little more accurately. And then I'll conclude with some general final comments. Okay, and just to be completely candid, these are my disclosures. So I've had a number of consulting roles. Mostly these are sponsors developing treatments for Alzheimer's disease, but we've also received funding through various positions, including my visiting professorship at King's College in London and my associate professorship at the Alzheimer's Centre in Amsterdam. These are all online if people do need to take a longer look. Okay, let's begin jumping straight into the issues with mild cognitive impairment and its diagnostic issues. So we have a set of criteria which we've worked with as best we can. They do represent some challenges, and what I'll do is I'll describe those criteria and then move to some consideration of how we might think about these issues and what the limitations on our current understanding might be. So we recognize that there's been a change in cognition by patients and a caregiver. And our experience actually is the caregivers tend to be pretty accurate. Most people close to us, it turns out, are fairly good at detecting whether there has been a change in our levels of cognition. Sometimes it will be related to memory, so difficulties remembering appointments, but other areas of cognition too. And I'll be talking about the breadth of cognitive deficits in the process of this presentation. We're looking for objective evidence of impairment in one or more cognitive domains, and I'll say a little bit more about that. Preservation of independence of functional activities, so it is people's day-to-day activity relatively unimpaired. And we're also looking for evidence that they're not frankly demented. That's, I think, a reference to some form of global dementia. And what are the challenges? Well, changes in cognition. It turns out that caregivers and patients are not too bad at identifying difficulties in memory. But for a lot of people, it's quite difficult, it seems, to identify that there's been a change in people's ability to think or organize themselves. So what we would classically think of executive function. Similarly, difficulties with concentration, what I'll refer to as attention. These seem to be less evident to people who associate these problems with some change in cognition. And possibly it's because we still think, I think, very much of Alzheimer's disease as a disorder of memory. I think we understand now that it's so much more than that, and that often the presenting signs and symptoms can be in areas outside of memory: executive function, working memory, paying attention, problem solving. Our experience at the clinic is that people are less able to pick up those changes and identify them with the risk of converting to Alzheimer's disease. We have a standard cutoff, ordinarily minus 1.5 standard deviations below expectation. This is often in the context of a memory test, though could of course be tests of other areas of function. And that represents some challenges that I'll come to in a later slide. And we also have this notion that people's preservation of independence is often very subjective and idiosyncratic, and that's typically very true of high-functioning individuals. It wouldn't be unusual these days for us to meet with somebody in their mid-40s in the clinic in Amsterdam who is presenting with difficulties in completing tasks at work. So they're aware that they're not as good at their job as perhaps they used to be, or indeed need to be. And sometimes that can be a very subtle deficit. Very high functioning individuals with very demanding jobs are often very sensitive to quite small changes in their cognition, so much so that we might not identify them on formal testing. And so a one look at an individual is often not as revealing as we would like it to be. That will segue into a later slide where I'll talk about some of the advantages of looking for change in cognition over time. And whilst not demented, frankly, so they might perform reasonably well on a global scale of cognition, we are aware they have deficits, as I mentioned in that last part of the presentation, sometimes very subtle ones, but nonetheless, they are present. And how do we go about identifying whether or not this person has a significant medical disorder with which we might help? We have clinical interview, we have lots of standard medical procedures that would involve blood draws, checking for various hormonal levels, and asking about things like depression. Depression often can masquerade as problems with thinking, and we might be induced into supposing that these people have dementia when in fact they may have a fixable psychiatric presentation. Neuroimaging has come on an extraordinary amount in the last 20 years. We now have technologies that simply weren't available to us in the past, and our resolution of imaging is now extraordinary. So we've really made marked progress, and we would be typically looking to exclude people with other conspicuous reasons for cognitive problems, for example, stroke, but others as well. And cognitive assessment, I'm going to be talking now exclusively about cognition. As a psychologist, I think I'm ill qualified to talk about other technologies, but cognition is very familiar to me and I think has a very key role to play in identifying patients with problems as well as monitoring them across time. And that's really now the focus of this presentation. So let's just take a moment to think about cognition. What do we mean by cognition? I think we have a fairly clear general view. There's some differences of opinion at the margins, but for me, this is really a quick gestalt of what I mean by cognition. These are for me the key domains of interest, particularly with respect to patients with mild cognitive impairment and Alzheimer's disease. So episodic memory, your ability to remember a new event. This is hopefully an enjoyable new event in your life, so you'll hopefully reflect fondly on this presentation, and that will be an episode in your life, so episodic memory. However, if I read you a list of 12 words and asked you to remember as many as you could, that would be potentially less interesting, but that would still qualify as an episodic memory event. Working memory, essentially that part of your cognition where you solve problems. So if I asked you to subtract 7 from 100 and keep going, as I would in the mini mental states exam, that would be a very good example of a working memory test. Attention, so your ability to concentrate, to pay attention. I think pay attention is a very telling expression. It makes it feel effortful, and I think often that can be the case, but essentially concentration. Executive functions, I'm afraid in most of the clinical trial work in Alzheimer's disease with which I've been associated, and I think more generally, a very neglected area of cognitive assessment, and I think that's to be regretted. I think difficulties with executive function can be very telling and have a very dramatic impact on the abilities of people to function on an everyday level. So executive function, planning, organizing, developing a strategy, thinking outside the box, a number of terms that come under this umbrella idea of executive functions. And language, essentially the output, I think, of a number of systems, but difficulties making yourself understood, difficulties maybe understanding what are being said to others. These are often characteristic of the patients that we would see in clinic. And finally, praxis. So your ability to manipulate the external world in service of a problem-solving exercise. So typically, we would ask you ideational praxis issues, maybe a manipulation of an object to ask you to salute, some of those nice Luria hand sequences that you might use. But it could be constructional praxis, so your ability to copy a figure. Clocks very commonly are employed, but equally more complex figures. This gives a flavor of your ability to represent something that's being shown to you externally and then replicate that by copying it. So praxis, whole host of things, but essentially those two things. There are other significant areas of cognition, but I'm going to focus very much on those 6 areas. And I think an obvious consequence of our recognition that you can have very specific cognitive difficulties is that's reflected in the various subtypes of mild cognitive impairment. So I think we're very used to the idea of amnestic MCI, people presenting with difficulties with remembering things, appointments, losing their keys around the house, a variety of things. But I think we've also reflected on the fact that there's a variety of presentations, and we can now see people who, in addition to difficulties with their memory, may well have difficulties paying attention, difficulties organizing things, difficulties manipulating their environment successfully. So what we would characterize as a multiple presentation. And there can be single domains of cognition that seem to be specifically impaired, possibly not memory, maybe executive function, possibly attention. We're now, I think, very used to the idea that people can present very variably. Oftentimes it will be people that have difficulties with memory, but sometimes the presenting cognitive difficulty could well be executive function, praxis, language, and a variety of other areas of function. Sometimes they'll be predominantly verbal. And I presume that the verbal and visual examples of MCI are a function of where the pathology is starting to build up in the brain. So we would expect, I think, medial temporal lobe damage to come with some difficulties with memory. If we had prefrontal lobe damage, that may well impact your executive functional abilities. And if your damage is more posterior, visual cortices, that presumably accounts for visual difficulties. And similarly, verbal difficulties may well correlate with classical language areas, the frontal operculum and other parts of the temporal lobe. So a variety of presentations, I think we perfectly well now understand that people coming to us in clinic could present with one or more of the cognitive difficulties listed on that previous slide. Now, there's a lot going on in this slide, but really I just want to focus your attention at the first 3 rows of this figure. This is a very conventionally and very commonly used outcome measure in clinical drug trials, quite possibly one that the audience here is familiar with, the ADAS-Cog. I think it doesn't represent the best practice. I think we could, should, and probably must do a much better job of assessing cognition in clinical drug trials than is currently the case, but to a very large extent, it's still very commonly used, and I think is seen maybe not as a gold standard, but certainly as a very commonly employed outcome measure. And there are elements of it that I think are actually very defendable, very helpful. I have some criticisms, but I think there are elements of the ADAS-Cog that are quite useful, and they tend to be the measures of episodic memory. So if I direct your attention to the very top of this figure, and we look at wordless delayed recall, what you can see is performance on a 10-word recall list. And you can see that the performance of the healthy age-matched controls is not perfect. So they are making some errors. They're not performing perfectly. That's a very helpful attribute for a cognitive test. And you can see in the light orange bar the performance of people with mild cognitive impairment. Now, they have an impairment. They're clearly not performing as well as the healthy elderly controls, but equally, they're not doing as poorly as the patients with confirmed Alzheimer's disease. So this, I think, represents our understanding of where you sit with MCI, and represents a challenge which I'll come to in the following slide. Let me just make the point that worst possible performance on delayed word recall on the ADAS-Cog. So the patient's capacity to remember a 10-word list presented 3 times, something like about 3 to 5 minutes after immediate recall, they're almost a flaw. So for very many individuals, even in the very mildest stages, they're only about 1 point from the worst possible performance that you might expect to see on this test. Now, that's very good for identifying cases. That's a very helpful metric. It's less helpful when people hit floor and we're looking at the effect of a therapeutic intervention. So floor and ceiling effects are to be avoided with cognitive tests, particularly when we're looking at cognitive change. And the challenge of detecting MCI, I've already mentioned that 1.5 standard deviation cutoff that we tend to employ. And I've mentioned the context of MCI where performance falls something like about midway between that of typical healthy controls and patients with confirmed Alzheimer's disease. And those dual issues do represent a challenge. So the challenge we have, I think, in detecting MCI is if you can think of these distributions on the right of my slide as representing performance on, for example, an episodic memory test, but actually a test of any of those cognitive domains that I discussed earlier. there's pretty good separation between the cohort of patients with Alzheimer's disease and those who are essentially typical controls, healthy individuals. There's probably a very little overlap in those two distributions, but a test of episodic memory in distinguishing people with Alzheimer's disease and typical controls, we usually expect to see sensitivity and specificity of around about 90%. So there's some overlap. Some poor performing typical controls can look a little like they may have Alzheimer's levels of performance, and very high functioning Alzheimer's patients can overlap with the normal healthy individual distribution. The challenge we have with MCI, I would contend, is that it sits neatly as a distribution between those two populations. So now you have significant overlap with both confirmed cases of Alzheimer's disease as well as the typical control population. And I think that's why identifying MCI still represents a very significant challenge for us. Worth mentioning also is if I replace that MCI label with major depressive disorder, that would be fairly characteristic of the levels of performance seen in perhaps first episode patients. So we often identify an impairment of somewhere between 0.5 and 1 standard deviation on a significant number of cognitive tests in a depressed population. And I think that's why the two populations are challenging to tell apart. MCI and MDD, identifying a cognitive difference is really just the start of our understanding of what these people's issues might be. So is there a solution to the challenge? I think there is. It requires follow-up, so longitudinal assessment, and it therefore comes at a time and a financial cost. But I think if I were looking for a methodology to be really sure that the individuals getting into my study of MCI actually qualified on the basis that I thought was important, this would be a general approach to that particular challenge. So let's think about some hypothetical examples. So this is my 1.5 standard deviations below the mean cutoff. And let's assume that the test of interest here is an episodic memory test. And you can see along the x-axis is essentially time. This could be very variable. It could be a short epoch, or it could be years. And up the y-axis are levels of impairment. Let's begin with this individual who's out walking and exercising, and he starts at a very high baseline level of performance. So this is a fairly able individual, typically at 2.5 standard deviations above the mean before the onset of any disease. But he changes very dramatically. He drops by close on 3 standard deviations in potentially a very short period of time, but he doesn't cross our magical threshold for identifying him as a case of MCI. So he's clearly the kind of person we would wish to see. However, he doesn't qualify because he doesn't meet the threshold. Now, a parallel course of decline is seen in this gentleman with his cocktail. Now, he starts from a less high baseline, so his baseline level of performance is less prodigious than our first individual. He changes at the very same rate, but he does get to a point when we see him where he has crossed our -1.5 standard deviation threshold. So that in particular individual would qualify, but I would argue it's the first case is just as interesting to us as the second case. It's just, as I mentioned, he doesn't meet our criterion. And then there are other individuals whose level of performance has always been at less than 1.5 standard deviations, and they would qualify even though there is no change in their cognition. They're simply performing at the levels of performance that one would normally have expected them to, given their baseline level of performance. So is there a solution to the challenge? I think there is, and I think what it requires is progressive evidence of systematic decline in areas of cognition of interest. And I think there are elegant and sophisticated ways we can do this. I think using a confidence interval around your initial performance, and then on subsequent visits, looking to see if you're now performing at a level that is outside of the confidence interval that we calculated for you at your first visit. You could see that this individual now has changed significantly. There's good evidence that even at this first follow-up visit, they have a level of impairment that means there's been a significant decline from our baseline, and subsequently that will continue, we would expect to be the case. Now, worth mentioning that cognition testing can be particularly useful in this context, but it does require highly reliable measures, and I'll be talking about what that looks like very shortly. So I think there is a solution. In the context of cognitive assessment, in contrast, I think, to the extraordinary strides forward we've made with biomarker assays, with neuroimaging, which have been, as I mentioned earlier, prodigious. We really have very substantially pushed on our understanding of how these individuals present using those technologies. But somewhat curiously, I think to me, and I know others, is that our approach cognitively looks rather medieval by contrast with that very cutting edge, innovative approach we've used it with other technologies. So somewhat curiously, we're still very wed to the mini mental states exam. This is nearly a 50-year-old test, and our understanding of cognition and Alzheimer's disease has markedly changed in that 50-year period. So I have to concede, I find it slightly odd that the MMSE is still very much a go-to test for identifying instances of individuals that we think may be presenting with early Alzheimer's disease. I think the Montreal Cognitive Assessment is a slight improvement, and I think the St. Louis scale similarly, but I still feel that there's a very important key role for a brief, reliable, sensitive, and new, potentially, outcome metric. Let's invest some of our research profitability and understanding in the last 20 years in particular of evaluating early stage patients and put that to good work with better outcome metrics. So what makes a good test? It's going to be reliable. It's going to hopefully change very little from one assessment to the next, unless there's been a truly pathologically driven change in cognition. It'll be valid. It'll measure the areas of interest. The mini mental states exam does not index very successfully or even at all attention, working memory, and not at all executive skills. So clearly not a valid measure for looking at early stage Alzheimer's disease. Sensitivity, really, really important. Can it show small changes? I understand perfectly the issues of the clinical relevance of that, but in identifying early stage patients, small changes might be very significant and tell us who is most at risk. If they can be brief, that's very helpful. And if they can be done by non-experts, then that's similarly the case. So simplicity in the assessment is going to be very helpful as a pragmatic response to making sure we get to evaluate a significant number of useful cases. So in sum, I would say a good cognitive test looks very much like a thermometer. Reliable, valid, and sensitive, doesn't require an expert. Even I can take my own temperature. And I think that these measures don't really give us what we're looking for. So I understand perfectly the appeal of a relatively brief, around about 12-minute assessment with a simple cutoff scoring scheme. I perfectly understand the appeal of that. But I think in the context of my earlier slide, I'm looking for something that's more reliable, more thorough, more comprehensive than is offered by the current measures that we tend to employ. Now, I recognize also that not everybody has the luxury of assessing cognition in clinic, and that sometimes there's a very significant time pressure. So I'm always very keen to explore the possibility there may be a number of ways of picking up individuals who are of interest to us potentially. If you don't have access to cognitive assessment, then I think there's a very practical alternative solution. This happens to be one of them, but I think there are a variety you might consider. This is the Perceived Deficits Questionnaire, the 5-item version, and it's, I think, a useful vehicle for a conversation with a patient or caregiver about the levels of cognition seen in the individual of interest. So you'll notice that from the questions on the left, there are questions that index memory, concentration, executive function. If you don't have the opportunity to evaluate cognition formally, and I would recommend that you do that where possible, this is, I think, a reasonable alternative approach to at least understanding the presentation of the person in front of you. And I think that there's plenty of room, as it turns out, for new measures that do give us what it is we think we need. So there are lots of digital alternatives. I'm a fan of many of them. I think people like Cambridge Cognition, Cogstates, Signant, ViraSci have done an outstanding job in developing very good state-of-the-art screening technology. It tends to be a little more expensive than paper and pencil assessment, particularly in clinical drug trials, and it does require access to the digital devices. So I think there's still room for a good paper and pencil solution. And I've been working with an international group of psychologists to achieve just such a thing. And I'll spend a little time talking about BASIC, which is one of the possible solutions to our need. But essentially, if I were looking to evaluate cognition in a relatively brief assessment, I'd be looking at some very simple, very well-known traditional paper and pencil paradigms. Phonological fluency, words that begin with a certain character or letter. Category fluency, typically the number of animals you can tell me in 1 minute. Some form of coding task, some form of digit sequencing, like a digit span, but in the particular instance here, you order the numerals in an ascending sequence. And I would always be very keen to incorporate a good 12-item list of episodic memory. And I want all these tests to come in at least 2 forms, just to mitigate the risk of too much learning from the first experience if we wanted to repeat them. BASIC is an attempt to remedy this. So BASIC stands essentially for Brief and Simple Index of Cognition. These are the 5 tests that comprise it. And as you can see, it focuses very much on episodic memory, executive function, and attention. And that's very deliberate. Expert groups with which I've been associated, including the European Task Force for Alzheimer's Disease, have focused very much on these early areas of cognitive change and identified those 3 domains as the ones we feel might be most at risk. And it should have good content validity. It should measure all the areas with which we're interested. It should be, where possible, have assay sensitivity. So has it previously, the paradigm, been shown to be sensitive to drug interventions? 4 of the 5 tests in BASIC meet that requirement. And it should be reliable, brief. This, as you can see, takes about 12 minutes. And it should be simple. So often the tests we borrow from clinical psychology were designed for very different reasons. And I think there's a lot of virtue to simplifying the instructions to make the assessment as easy to give and as brief as possible. Just to give you a flavor of what the inventory test looks like, here's a very brief clip of me assessing somebody.
I'm going to read 12 words to you out loud. After I say each word, I want you to repeat it back to me and try to remember it. Once we finish the list, I will ask you to tell me as many of the words on the list as you can remember. Do you understand the task?
Yeah.
Are you ready?
Yeah.
Okay, let's begin. Drum.
Drum.
Bell.
Bell.
School.
School.
Moon.
Moon.
So a very conventional wordless learning test, 12 words. You'll see that I've asked the study participant to repeat the word back to me. That's really just to ensure that they do process the word. Some tests, like the regulatory verbal learning test, we simply read the words out loud and don't require any repetition. So it's always not quite clear whether the patient is paying particular attention. Having them repeat it back ensures that they do so. This is the kind of test I think would be particularly useful. As you can see, instructions for the test are very, very brief, and we deliver 2 trials just to capture a reasonably wide range of possible performance. This is subject to validation, so here's some early data. It's essentially showing no floor and ceiling effects in a typical control group, with a relatively good relationship between mean and standard deviation. So there's not very noisy data. And as you can see, there's a relatively small spread of performance. There's ongoing data collecting yet more examples of patients with Alzheimer's disease, but early evidence suggests the sensitivity and specificity is hitting around 90% for both. We'll be reporting this in more detail later in the year. So essentially a measure of cognitive change primarily for use in clinical drug trials where digital testing perhaps isn't such a useful option. Could also be used as a measure of cognitive status, I think not just in Alzheimer's disease, but other indications too. And one of the things we're very keen to do is to ensure that we have a variety of language versions available very early on. So I've been working with an outstanding cohort of psychologists from around the world, developing a number of language versions. Currently, we have 25 available, including, you'll be pleased to hear, I'm sure, Croatian, but also Japanese, Arabic, Farsi, and Tagalog. So we are very ambitious to ensure we have good international coverage. We have a very grand plan to make BASIC available in all possible languages, and that's probably going to take us a little while, including unwritten languages. So we are in the process of developing sound files that could be downloaded by individuals where the language doesn't have a written form, so that they can get a flavor of the content, and if they chose to, administer the test locally. So that's the end of my presentation. Very briefly, just to sum up, mild cognitive impairment is of significant interest. The therapeutic interventions that we will hopefully have available probably will perform best early as we can possibly get into the patients who are presenting. So there is a big premium on identifying individuals very early in the disease process. We could, should, and I think must improve the quality of the cognitive outcome measures that we use, not just in clinical research, but also in clinical drug trials, so that we can meet the extraordinary levels of quality, validity, reliability, and sensitivity that we've achieved with biomarker assays, neuroimaging, and the other technologies. At that point, I'm going to stop. Thank again the organizers. Enjoy the conference. If anybody would like to contact me, I'm always delighted to hear from you. And here are a variety of means by which you might send me a message or connect with me. Thank you very much, everybody, for listening.